I'm going to review 4 different case studies and case series that look at patients presenting with shoulder pain. And what's important to note is that 2 of these studies have the patients resolve their shoulder pain with movements of the neck. But what the 4 studies I've chosen highlight is that the diagnosis in all of these patients is a joint derangement, which is a diagnosis created by Robin McKenzie starting in the 1950s. And a joint derangement is not a tendinopathy, it's not a slap tear, it's not a muscle or tendon tear, it's not a bursitis, it's not any of those commonly used orthopedic diagnoses that are absolutely true in rare occasions. But what I find, having learned Robin McKenzie's work and implemented his repeated movement testing as part of my orthopedic evaluation, is actually the backbone of my orthopedic evaluation, is that most patients have joint derangements. So joint derangements, quickly as a review, they create local and or referred symptoms. They are characterized by a range of motion that's either lost or painful, and that's usually visible to the naked eye, especially in the extremities. It's almost always, if not always, visible when you take the baselines of range of motion. It can present with weakness, meaning a manual muscle test is weak. It can present with nerve tension, but the crux of the matter is that a joint derangement, by definition, has those characteristics and responds to movement into a specific direction repeatedly. So if you have all these things, but you don't respond to a directional preference movement, you could have a slap tear, or you could have a fracture or a dislocation or a number of different things. So you use repeated movement testing to see if that disorder responds to movement in a very specific direction, and we call that the directional preference. So going through these 4 studies, 2013, Atona and Dudley did a case series. They had 4 patients, and the onset of symptoms, 2 reported that it was just gradual onset of shoulder pain, 2 remember that there was a specific incident that created the shoulder pain. Symptoms were present anywhere from 2 months to 18 months. The number of visits to resolve the shoulder pain were 3, 4, 5, and 3. And the DP, or directional preference, for these patients, for 1, it was functional internal rotation, which is also known as ham behind back. It's internal rotation of the shoulder joint, but it's behind the back, commonly called FIR or HBB. For the second patient, it was shoulder extension, which is moving the shoulder joint back into extension. For the third patient, they used functional internal rotation and then subsequently extension with overpressure. And 1 was internal rotation at 90. So the patient's arm is kind of supported on the wall at 90 degrees of flexion, and the patient is pushing into internal rotation. I remember back in the day, I would give a lot of patients with shoulder complaints the sleeper stretch, which is also shoulder internal rotation at approximately 90 degrees of flexion, but it's in side lying. And one of my hypotheses, now that I've gotten more proficient at repeated movement testing and finding patients with the directional preference, which is 70 to 80% of patients, is that I think the shoulder, the sleeper stretch, is the mechanism that it's helpful is not that it's releasing the posterior capsule. I think for those patients where it's significantly helpful, it's likely moving the joint in a way that would be akin to a directional preference. So this highlights how few visits these patients need. By using repeated movement testing, you can find out quickly, do you have a direction of preference for this shoulder joint? Is it a joint derangement? And if not, if the repeated movement testing shows there's no evidence for moving repeatedly into a specific direction, then as clinicians, we start to think either day 1 or day 3 or day 4, whatever it may be, this is maybe structural, maybe it's inflammatory, maybe it's a tendinopathy, etc. We try to get that answer as quickly as possible, but if you're on the right track, then compared to what I used to see with patients before I started using MDT, averaging 3 or 4 visits for a lot of patients, or 4 to 5 visits in total for all your patients, is pretty ahead of the curve. I don't remember hardly ever discharging shoulder patients after 3 or 4 visits before I started using Robin McKenzie's repeated movement testing and finding that a lot of these patients just need to find the directional preference and get them moving repeatedly into that, and likely simultaneously avoiding things in the opposite direction, or especially things that are aggravating to the patient's symptoms. Second study, 2013, Josh Kidd did a case study that highlights one patient, symptoms for 3 months, no incident that the patient recalls as starting the shoulder pain. He discharged this patient after 3 visits, and the directional preference was horizontal adduction. And I think I've alluded to the patterns that we tend to see with shoulder joint derangements. Horizontal adduction across the body is the third most likely that we tend to use. Internal rotation and extension, as highlighted in the first study, are the top 2 directional preference motions that we find, but they can be performed in different loading strategies, right? Internal rotation here, internal rotation here, internal rotation here, or extension. Extension is a little bit more straightforward. Typically, we're doing overpressure with the arm or shoulder internally rotated, the palm up, and the patient squats down to get end range shoulder extension. But you can also use something like a golf club to push it back. The variation there might be whether or not the shoulder is internally rotated or neutral or externally rotated based on where the palm is with the position of the hand. But horizontal adduction is also, like I said, probably the third most common directional preference that we find for a diagnosis of joint derangement. So that one's pretty straightforward. Now we go to 2012, Menon and May did a case study, and again, this one turns out to be, despite complaint of only shoulder pain, it turns out that it was referred pain, if you will, from the cervical spine. So the cervical spine was used as the directional preference, but it's one patient, symptoms of 4 months, no recollection of an inciting event, 5 visits, and the directional preference was retraction, and then retraction, extension. And this case study was great because it highlights all these findings on the shoulder MRI, including a complete rupture of the subscapularis, hypertrophic changes, inflammatory changes, tendinosis. It was kind of a ugly MRI, if you will, but all the pain went away with some neck motions. And what was interesting is, I think a contributing factor to this patient's symptoms was sitting on a relaxed position, on the couch, watching TV for several hours, which doesn't do much in terms of positioning the shoulder in a deleterious way, but it does put a lot of stress on the cervical spine if you tend to be flexed for hours on end, possibly, day after day after day for many months or years. So 2021, Hathcock, Boyer, and Morris did a nice patient case series with 3 patients in the U.S. military. 1 had a gradual onset, 2 had sudden onsets of the primary shoulder pain. Symptoms have been present for the gradual patient, I think about 3 months, and for the sudden onset patient, 6 days each. The number of visits to discharge was 5, 4, and 6. The directional preference of the cervical spine in these patients was retraction and extension, and then extension. In prone, retraction and then retraction, extension. And then for the other patient, it was left side bend, and then left rotation, and then retraction, extension. And this patient also needed some oral steroids to address an inflammatory component of the patient's symptoms. This case highlights also how these patients had already received shoulder diagnoses and just were not getting better. And so when they were taken through the repeated movement testing, it was found that they had an origin of symptoms in the neck. And I believe they all had clinically meaningful decreases in pain at 10 days and returned to duty in about a month. So again, seeing patients for 5, 4, and 6 visits, seeing patients for 5 visits, seeing patients for 3, 4, 5, and 3, and seeing a patient for 3 visits, in my mind, that's way ahead of the curve. It's definitely ahead of the curve for what I used to see patients for before using repeated movement testing years ago, when I would see patients with a primary or only complaint of shoulder pain. So what I'm trying to get at is I wish more orthopedic clinicians used repeated movement testing, because when we use repeated movement testing, it guarantees, or at least it gets us much closer to a guarantee of getting the right diagnosis. Because even though there can be tons of findings on an MRI and anatomical problems exist, you need some way to tease out if that anatomical problem, either found on an MRI or deduced by a quick orthopedic special test, is truly the pain generator. So you can think of repeated movement testing as a way to tell you if a positive test that you already took is actually positive and relevant, or if it's positive but not relevant to the symptoms, or it's a false positive. So repeated movement testing is the main thrust of what I do when it comes to patients. And typically this bears out in better patient outcomes. And I think that's demonstrated by faster discharge, fewer visits, more inpatient empowerment, because manual therapy is rarely even used much when we start to find these directional preference movements for patients. We teach them how to do FIR, we teach them how to do extension. And if we use manual therapy in the clinic, it's often more an assessment versus a therapy. So we need more studies, of course, but I think interested clinicians can find studies like these and start to say, okay, I average 8 visits with my patients with primary shoulder pain. How can I cut that in half? Or how can I cut that at least by 25%? And unfortunately, I don't think there's a lot of medical groups out there who are very interested in reducing visits, because visits are how they produce income. But from a patient perspective, we want to get better as fast as possible, obviously with the least amount of work possible and the least amount of expense possible. And by having clinicians who are able to find these diagnoses that are faster to resolve than tendinopathies, right? They are faster to resolve than most structural lesions. Then we're getting people out the door faster, and people are generally in a better place.